the atypical optic neuritis. So we had a typical, which has been presented by Dr. Diksha, and the infectious optic neuropathy, which is a type of atypical optic neuritis, where we have to ask for investigations if we feel the clinical picture resembles so. So coming to the immune-mediated, like which we call the neuromyelitis optica spectrum disorder, associated optic neuritis, also commonly called atypical optic neuritis because it does not obey the visual acuity and the investigative modalities. They're all different for that, and how they present is not that typical. So it's a severe inflammatory demyelinating disease which affects the optic nerve as well as the spinal cord. So many people will present with spinal cord pathologies as well as causing weakness. So it's a distinct disease, and you have antibodies against it with like aquaporin 4 and myelin oligodendrocyte protein, which we call the MOG. So aquaporin 4 and MOG, basically, if you have positive, then you call it an NMOST. So the presentation is, there's a lot of overlap in these presentations. So there's no pathognomic way this disease would present. Usually I say it could be a severe visual loss. It could be bilateral simultaneous optic neuritis. When you have spinal cord involvement, it's like longitudinally extensive transverse myelitis, or you could have intractable hiccups, nausea, and vomiting. So that's a typical area prostrema syndrome. And if you have that one, symptoms of these, probably you could narrow down your diagnosis to an NMOST. Relapsing course, yes, the MOG positive patients do have a relapsing course, sometimes even with immunosuppressive or immunomodulatory treatment. The weakness is because of, again, central nervous system involvement, the spine involvement, the bladder bowel dysfunction, and pain are because of the CNS involvement. So the diagnostic criteria of NMOST was well described in 2015. So if you have these positive markers like aquaporin 4, then probably along with one of these core characteristics like optic neuritis, acute myelitis, area prostrema syndrome, which includes hiccups, nausea and vomiting, or the acute brain syndrome, symptomatic narcolepsy, or cerebral syndromes, or even focal involvement of the brain. If you have a positive aquaporin 4, then yes, we are dealing with some kind of a NMOST. But what happens if you have a strong suspicion, but you get your testing done and it's negative for aquaporin 4? So then what we have to think about is the clinical characteristics. So you have to have two core characteristics, with one of them being out of the most common. The most common means out of these four, either you have optic neuritis, a myelitis, a prostrema syndrome, or a brainstem syndrome. So these are the common ones. So one of these has to be there along with any other to basically diagnose them as NMOST. Of course, they may be negative in the beginning, but after 3 to 6 months or maybe a year, many would seroconvert. So the NMO consortium has said that about 50% of these patients, so they would not present to an ophthalmologist, they could present to a neurologist with the form of transverse myelitis with weakness, pain, or maybe bladder or bowel disturbances. Optic neuritis is seen in 36%. Both of them are seen in 10% and neither in 4%. So when do you want to test for these markers in a patient who presents to you with maybe decreased vision? The aquaporin 4 is positive in 3 to 5% patients with the first attack of optic neuritis without neurological features. So a fairly very less number of people have a positive aquaporin 4. They might seroconvert later, and the way it's tested is also very important. So you need to have the clinical characteristics along with that, which are the two core characteristics. You could have bilateral visual disturbances. That's again atypical. So to have both eyes visual loss, maybe asymmetrical, maybe sequential, or maybe simultaneously, it gives a clue that this is something atypical. Recurrent optic neuritis with poor visual gain, where MRI is not typical for MS, is also a clue that you're dealing with NMOST. Coexisting autoimmune disorders, yes, if you have kind of a maybe SLE type of an issue or maybe other things, you should test for this immune-mediated NMOST. So which lab test to order? Now this varies from place to place, and that's how the literature says you might have a positive antibody or you might have a negative antibody. This is all based on testing. So the most sensitive is the cell binding assays. So again, the specificity is much more as compared to sensitivity. So the thing is, you could have just the negatives, true negatives are much more as compared to the having a true positive. So the ELISA is slightly less sensitive, and previously, like indirect immunofluorescence was done probably just positive in 50% of the cases. So once you test it, and that is one part. So once you have the antibodies to your aquaporin 4 or myelin oligodendrocyte protein, then it's a confirmatory evidence. But yes, there are false positives as well. So the other modality which is very important in helping us manage this patient is MRI. So MRI findings, as was shown earlier in the typical optic neuritis, usually you have like the anterior segment, in the anterior part of the optic nerve involvement, whereas in these cases, more than 50% involvement of the optic nerve. There is bilateral involvement. There could be chiasmal involvement as well. And if you see the spine, I mean, there's a longitudinally extensive intramedullary lesions which span 3 vertebral segments. So 3 or more vertebral segments would definitely favor a diagnosis of NMOSD. Whereas less than that, probably you would still think about maybe an MS type of a lesion. But yes, follow-up would be very essential in those cases, because what happens is these can be, it also depends when you do these MRIs, it could be patchy lesions. So a single lesion broken up into patchy lesions. So that also, it all depends if you're doing it too late. So the right time probably to do it is in the initial few months. Brain MRI again would tell you what lesions are there in the brain. It's normal in 40% of these cases. So NMOSD can have nothing in the brain. I'm not talking about the orbit or the optic nerve, and chiasmal involvement, that's different. But otherwise, if you see the white matter, there could be nothing. Some spots are seen in 46%. It could be MS resembling in 13% of the cases. So these are just to show you some of the images here of atypical optic neuritis, or you can say NMOSD or optic neuritis. You can see here the involvement, the swelling of the optic nerve, and it's way beyond. In case of MS, probably you might just have just the anterior part, but it's extending more than 50%, almost reaching up to the optic chiasma. Just see how it's swollen. There is some, you can say, a perineural enhancement as well. Probably that would point towards a MOG lesion here. So these things, MRI is helpful in this orbital lesion. We are not seeing anything in the brain here. Similarly, you have another case here. Again, thickening of the optic nerve, enhancement in probably 2 regions here, but it's quite thick. So the whole length is involved. It's an intracanalicular portion and going posteriorly from anterior to posterior. This is another case of NMOSD where you can compare. We see here that 1, 2, 3 parts getting involved, and there is some intensity here near the chiasma, and the other eye is also getting involved. So these are some of the features of atypical or NMOSD optic neuritis. And if you see the spine involvement here, you can see here the enhancement, which is probably 1, 2, 3, 4, almost 5 vertebra. So it's more than 3 segment involvement. And this is the central part which is getting involved. It's not the sides which are getting involved. So these are some of the features where if you have a negative aquaporin 4 or MOG antibody, can give you a clue that yes, this is something where I need to treat the patient very aggressively to prevent further disability. So when you talk of treatment in these cases, the acute management is with the methylprednisolone. So whether it's an atypical or a typical variety, the management is methylprednisolone 1 gram given for 5 days. We have to be careful here. Some of them don't respond. So if there is no response, probably the earlier you do the plasma exchange, plexus plasma exchange. So it should be done as early as possible, because the more we delay, probably if you do it after maybe 15 days, the effect is much less. Many still don't recover pre-baseline vision in patients with aquaporin 4 positivity. And a long-term treatment, of course, you would require immunomodulators in consultation with the neurologist. So when you talk of MOG positive, so these aquaporin 4 and MOG and all, I mean, they are part of that neuromyelitis spectrum disorders. But really, if you speak of NMO, probably we are concerning about the aquaporin 4. So this is also, you have an antibody to the myelin oligodendrocyte protein. And this is more often it presents as an isolated optic neuritis, more commonly than a transferred, but usually with transverse mellitus. So it's more of an optic neuritis. The phenotype type is similar to, you can say, an aquaporin 4 optic neuritis. Recurrences are more prevalent, just like chronic relapsing optic neuritis. Earlier it was cryon, but now we've got these biomarkers. So probably we can they fit into one of these categories. The visual loss at presentation can be profound, but the good thing is that it responds well to steroids because it involves the anterior part more often. Although more than 50% of the optic nerve is also involved, but has an anterior predilection, you have more of disc edema in these cases. So how it can present? A MOG and antibody disease can have a varied presentation. It can present as ADEM, that's acute disseminated encephalomyelitis, usually seen in children. So if you have like ADM in children, probably, then you're more or less going to get a MOG antibody positive response. So in children, this is the picture. What we have is what we call as an ADEM. Then unilateral optic neuritis is seen in 31% of the patient. It's a recurrent optic neuritis. You could have a profound loss of vision as well. Bilateral optic neuritis is seen in 24%. You can say longitudinally extensive transverse myelitis in 14%, and a combination in 9%. So it can present just anyway. So if you think you have such kind of a picture, what you're dealing with, probably, then you can order. You can suspect that it's likely to be a MOG antibody positive. Now, imaging again will help you in narrowing down your diagnosis, because you have more than 50% optic nerve involvement. Chiasma is less commonly involved. The important thing is perineural enhancement, which is very common and very unlikely to be seen in aquaporin 4 or MS-related optic neuritis. So if you have a perineural enhancement, you have more than 50% optic nerve involved, which is mainly the anterior 50%, probably we can order a MOG. So just to tell you about the red flags in atypical, or you can say the atypical signs and symptoms of optic neuritis. So I won't be going with the typical one, which has been covered. The atypical variety probably presents, you can have more than 50 years or less than 12 years. So it's children. So the MOG related events are commonly seen in children, or you can have in young adults as well. The visual loss could be sudden, it could be profound, or it can linger on for a few weeks. The severity of visual loss can be no light perception as well. It could be bilateral no light perception of light. Pain is a distinct marker of, you can say, optic neuritis, but atypical symptoms means no pain. So if you have no pains, probably you're dealing with some kind of an atypical variety. Previous history of neoplasias, paraneoplastic syndromes can present, or you have autoimmune disorders, connective tissue disorders, sarcoidosis and vasculitis can present with this. Optic disc edema is more likely to be seen in MOG-related disease, and it's a severe optic disc edema. Severity would be much less in an MS-related optic disc edema. Then you could have related uveitis or periphlebitis. NMOs presenting later could have just optic atrophy, and then you would unable to regain the vision. In a typical variety, vision would usually recover in 2 to 3 weeks, but here, if you have a aquaporin 4 positive, there are chances that you may not have a recovery. So these are some of the red flag signs which tell you how, which you have to look for and see whether this patient would require intensive management. So this has already been covered. Just to revise it, what it is basically, the laterality of attacks is bilateral in NMOSD, very unlikely in MS. The severity of visual loss is much more. White matter lesions are more seen in MS-related disease. The optic nerve involvement is anterior orbital. It's posterior in NMOSD. The transverse myelitis is rare in MS. You can have just maybe a single vertebra involvement, but yes, it is there. It's common in NMOSD because, as I said, 50% could just present with transverse myelitis. Tissue destruction, cavitation is more in a aggressive disease, which is NMOSD. CSF analysis, proteins are much higher in NMOSD. Response to steroids is good in multiple sclerosis, and reasonably good in MOG-related NMOSD, but it's quite variable. It's difficult to predict in a aquaporin 4 positive NMOSD. So this is just a flow chart which can guide us to approach a case of optic neuritis. So if you're suspecting optic neuritis, you can have typical symptoms or atypical symptoms. So you would order obligatory blood test, maybe typical or atypical. So once you're considering atypical, you have to see if you're dealing with inflammatory optic neuritis. The clinical picture, the history, the symptoms would tell you. Infectious optic neuritis is a beautiful finding as shown by Professor Vishali Gupta. then you have to be careful about these conditions. These are all, you can say, mimickers of optic neuropathy and optic neuritis, ischemic optic neuropathy, because it can present with disc edema with sudden vision loss, so atypical symptoms. One has to be careful about this, how the patient presents, and the you can say the findings on the fundus exam, the finding of the optic disc, see the other eye, whether there's a cup or not. So all these are clues. Compressive optic neuropathy usually would be bilateral. So in the initial phases can present as disc edema. Toxic, usually patients would give a history. Inherited optic neuropathies are slow growing, you can say slow loss of vision over time, and probably a proper history is available. It's not that acute as seen in the optic neuropathies, which are atypical, and other causes like uveitis and all have to be ruled out. So further diagnostics have to be carried out based on what your clinical impression is. So MRI brain and orbit probably would be done in all cases. A CSF analysis where required if you have, if you feel there's some kind of an infective pathology in the CNS or which is causing it, or you're unsure of what type of neuritis you're dealing with. Probably yes, along with additional blood test, and the specific diagnosis and treatment is all based on what the final diagnosis is. So the specific diagnosis, I mean, the acute management is, yes, in many cases, if you think of an immune-mediated disease, it would be intravenous pulse methylprednisolone. So if you have typical symptoms, you can consider a MS or maybe a clinically isolated syndrome or a single attack of optic neuritis. MRI brain, of course, that's what you have to do, get done in probably almost every case. So if your suspicion is if we have MRI finding probably on the brain imaging, then the patient has probably high risk to develop MS. The acute management is IV corticosteroids. But if you don't have these findings, the chance of developing MS is there, but you still have to treat with IV corticosteroids. Follow-up and MRI and examination is very important in both these cases, because these patients at the onset time, as I said, there's a lot of overlap. So you don't know what can the patient be having later on. If you might have a relapse in the first year, might not have a relapse for maybe a couple of years. And what happens in the second attack, what amount of vision loss the patient has, how he seroconverts, all these are important. So the follow-up is very important in such case. You just can't leave the patient who has had one attack and okay, fine, just go away. So the acute treatment, as I said, in these cases is IV MP for 5 days, followed by oral steroids. Oral steroids really help in patients with MOG-related disease probably. You have to carry on these steroids for maybe a couple of months. The second line treatment is plasma exchange or IVIG, and these are patients who really don't benefit from IVMP. So if we have a patient who has loss of vision and has probably is unable to regain vision after 5 doses, after considering other diagnoses, he might be a candidate for plasma exchange. Immunosuppressive is a specific therapy to be given, which is a chronic therapy, and obviously this is to be done. This is done by the neurologist, where the first line therapy probably followed is azathioprine and rituximab. Rituximab, yes, you have you can say lesser dosing as compared to azathioprine. The second line is methotrexate and mycophenolate. So I'll just discuss the algorithm for the management where you have these MOG antibody positive or a negative. How to approach these patients. So this is what I'm going to talk about is like an atypical optic neuritis. So atypical optic neuritis could be just anterior with papillitis, bilateral, an optic neuritis with poor recovery. You're having a recurrent optic neuritis or maybe a transverse myelitis along with. So number of causes as I discussed, I mean, it could be ADEM, it could be brainstem or transverse myelitis. So how do you approach this? So if the patient tests, so you have to send antibodies for aquaporin 4 as well as MOG at the same time, preferably before starting steroids. So it has, in some studies, it has been shown that these results could be altered if you start IV methylpred before sending the samples. So you just take the samples, keep it, and you can send them for the investigation. So if you have a positive test for MOG antibody, what do? You call it a MOG antibody disease. You treat with 6 months corticosteroids or immunosuppressive therapy. And then what happens is, again, testing MOG antibody at 6 months. So if there is no MOG antibodies, probably you can taper off the corticosteroids. But if you have a positive, then of course the onset, the attack, severity of the relapse, severity at presentations could give you a clue that how long you could consider. So at 6 months also, there's MOG antibody, you have to continue the corticosteroids or the suppressive therapy. Again, test at 12 months. So if nothing, taper off. If there is a MOG antibody positive, then probably the patient is relapsed. You have to discuss long-term immunomodulators which are specific to the MOG antibody. So if you do not have a positive antibody, then probably if you have a aquaporin 4 positivity, yes, you deal that way. If it's not there, then probably you would think of ADM or MS or maybe LETM. All these things, I mean, these are differential diagnosis, autoimmune disorders, other autoimmune disorders, and other causes of optic neuritis. So that's how you have to deal with patients who present with atypical optic neuritis. So investigations have to be tailored to clinical suspicion. MRI, why you want to do MRI is obviously to rule out MRI of the brain, to rule out lesions other than MS, and maybe if you have MS-like lesions, you prognosticate MS. The other thing is MRI would help you show you the length of involvement of the optic nerve, which again is one of the important signs when you're dealing with atypical optic neuritis. So MRI is really probably even for typical and atypical, you can say MS and non-MS related optic neuritis is a really helpful investigation. CSF analysis is done if you find that you're not really getting along with these MRI or something very atypical, something you find that is suspicious and not fitting into your diagnosis, you could do a CSF analysis along with that. Serum vitamin D, although not directly related to optic nerve damage, but it's a risk factor for recurrent optic neuritis. So always get a vitamin D levels. And in this Indian population, probably people are deficient in vitamin D, no harm in starting out them vitamin D. The antibody testing, yes, if you're suspecting NMOSD, go ahead. Even when you're having a, you can say, a typical variety of optic neuritis, probably sometimes it's helpful to get these things done if your MRI is normal, and to rule out a vasculopathic, paraneoplastic, infective workup if suspected. OCT is a very handy tool for the ophthalmologist. In the OPD, takes hardly a minute or so to do it. And yes, in some patients, yes, it can help in giving us, you can say, prognosticating and helping us in treat, and sometimes even getting the investigations done. The amount of loss on the ganglion cell is helpful to know the severity of the disease. So it would basically thickening of the RNFL in acute phases. That's if you have a disc edema, probably RNFL will be thickened in those cases. Thinning of GCL IPL is more in NMO. So if you have a severe thinning, probably it would go more in favor of a NMO spectrum. Then clinically, microcystic macular edema is indicative of NMO. You can have wedge-shaped defects, but remember, wedge-shaped defects are more prevalent in ischemic pathology. So in the era of biomarkers, we look at optic neuritis. How we look at optic neuritis has changed. The pattern of optic nerve enhancement on MRI would provide us diagnostic clues to the etiology. And it also helps us understand the mechanism of the disease, thus influence the treatment. So a lot of things, I mean, the MRI provides us a lot of information. Of course, this is added on by getting tested for aquaporin 4 and the MOG antibody. So it's very important to know that these categories, these antibodies and these antibody-associated optic neuritis, are separate entities with different prognosis, with different presentations, underlying pathophysiology. But yes, there is treatment available. So one should be quick to pick up these entities and start treatment. So we had these 3 presentations which covered almost, you can say, the commoner varieties of optic neuritis. And with this, after this, you can say the theoretical part, probably we have a few cases, and we can discuss those cases here. And I like Dr. Deeksha and ma'am, Professor Vishali, if she's available, she can like to have the comments as well when we go on these cases.